Welcome, everybody. My name is Ketan, Dhatariya, and I'm the immediate past president of the Diabetes and Endocrine section of the Royal Society of Medicine. This, as you know, is the RSM Live series on COVID-19, and this is episode 90. And we have got a fantastic panel of speakers with us today. We've got Dr. Lucy Chambers, who is the head of Diabetes Research Communications at Diabetes UK. We have Professor Martin Rutter, who's Professor of Cardiometabolic Medicine from Manchester. And we've got Dr. Shivani Misra, who is a consultant in metabolic medicine from Imperial College in London. Now, I would like, if you would, please to put your questions into the Q&A function at the bottom of your screens, and we'll try and get to as many questions as we possibly can. We've already had loads of questions come in, and we're trying to get through them as much as we can. And I apologise in advance if we don't get to answer your particular question. So, without further ado, welcome everybody. Thanks for joining us this afternoon. So, may I start with you, Martin? I know that you've published recently on the effect of COVID and how people can access care and what the outcomes of potentially the lack of access is. So can I just ask you to expand on the stuff that you published in The Lancet earlier on this year?
Yeah. We had a paper this week which is looking at the impact of the restrictions that COVID has imposed on us during the COVID pandemic. So between March and December of last year, we looked at primary care data, and we identified that about 7.4 million care processes didn't occur that we would have expected to have occurred based on historical trends. So there's a lot of difficulties in accessing primary care, obviously, in the last 18 months or so. And we quantified really the amount of work that hadn't been done during that time. So primary care is in the news very much at the moment, and people are quite keen to see that primary care opens up and this work is done, and maybe we can talk about ways that can be done later.
So Lucy, can I bring you in there and say, and Diabetes UK is obviously a point of contact for a lot of people with diabetes. What is your experience? What have people been contacting you for? Have the issues that Martin just mentioned, the lack of access of care and that kind of thing, has Diabetes UK been contacted about that kind of thing?
Yeah, they have. So, the needs and concerns of people with diabetes have really changed as the pandemic's evolved. So when we initially locked down, we went out to our supporters and asked them what they were concerned about. And at that point, before we'd learned about the statistics on who was at risk of dying from COVID, we learned that people were concerned about access to healthy food. That's when we were really locked down and not going out, getting enough physical activity, getting access to their healthcare team. And then as the pandemic's evolved and data's come out showing that people with diabetes are at increased risk of serious illness from COVID, we've done a lot of work to help people understand their risk and what that means to them, because it's not as simple as everyone with diabetes has a high risk. It's much more complicated than that. Everyone has their own unique risk, as we all know. So we did a lot of support around that. We also learned, as we're coming out, or hopefully emerging out of the pandemic now, that people's concerns really about access to healthcare, what healthcare looks like for them as we enter this new world. And as Martin said, getting those checks that they need to keep their diabetes well managed, and the support for that as well. And concerns around mental health has come out from our supporters as well, the impact of the pandemic on how they're coping with their diabetes.
Thanks. I'll come to Shivani then, because I know, Shivani, I was going to show this came through my letterbox this morning, the current edition of The Lancet, and Shivani, you're a lead author on a paper that actually you and I worked on in terms of DKA and admissions, and there was a differential effect in people with type 1 and type 2. I just wondered if you could expand on that.
Yeah, thanks, Ketan. So everyone that was working in a hospital during the first wave will remember that it felt like there were a lot of ketoacidosis cases coming in, and not the sort of typical ones that we see in people living with type 1 diabetes who have a precipitating factor for some reason. So we were really in a lucky position to look at national data on this, and what we saw was that in both the first and second wave, the number of diabetic ketoacidosis admissions reduced in people living with type 1 diabetes, but actually disproportionately increased in people living with type 2 diabetes compared to pre-pandemic levels. And also of note, the cases were higher in people with new diagnoses of diabetes. And by that, I mean that they were presenting to hospital in ketoacidosis, and this was the first time that they'd been detected to have diabetes. So we saw, as you say, differential trends between type 1 and type 2. And the type 2 diabetes cases were demographically quite similar, we think, to the people that were most at risk of severe COVID. So classically older people, people from ethnic minority groups. And so, yes, you know, it turns out that the ketoacidosis story is not a simple one at all.
So let me ask you a question on that then. One of the issues that we discussed previously, and others are discussing all the time, is that whether COVID precipitates DKA, or rather does COVID precipitate diabetes? Because we talked about whether this was an increase in number of new cases or people who are already existing. So Shivani, let me come back to you again. What do you think about that? There's a question about whether COVID precipitates diabetes. And actually, I would say to the audience who are watching, that's actually one of the most frequent questions that's been submitted and coming up. Does COVID cause diabetes? So Shivani, what do you think?
I think it's such an important question, but I'm just not sure that we know the entire answer to it at the moment. And I think it will turn out, my gut feeling is that it will turn out to be multifactorial. So there will be a category or a group of people who probably had diabetes that was never detected. They then got coronavirus, came to hospital or sought medical attention, and that was the first time their diabetes was found. So COVID essentially unmasked pre-existing diabetes. There's also a story, there have been a number of studies looking at whether the SARS-CoV-2 virus can actually enter into the pancreas and potentially harm the cells that are making insulin in the pancreas. And I'm no cell biologist, but my understanding of those literature at the moment is that some of the data are conflicting as to whether or not the virus can actually have an effect itself on the insulin producing cells. And then there are other facets here around, the concept of any viral illness inducing an autoimmune condition. And we know that type 1 diabetes, for example, can occur after viral infection. So I'm sure that there are other factors that the others might want to discuss as well, but I think it will be very, very difficult to actually disentangle all of this because of the huge behavior change and the changes to society that went on during the lockdowns. I think it will take years to sort of disentangle what's going on here.
Thanks. Martin, any comments, or Lucy, any comments?
Yeah, thanks, Ketan. Yeah, I think it is a mixed bag of etiology. The undiagnosed is certainly there, and possibly effects of the virus on the pancreas. Stress hypoglycemia may be a factor as well. So being seriously unwell can cause insulin resistance. And of course, people have been treated with steroids quite a lot during the last few months, and that will have contributed to diabetes as well. It certainly looks like there is a signal. There is an increased risk of people developing diabetes after they've had COVID. I think in some bigger studies, about 5% of people who don't initially have a diagnosis of diabetes actually develop diabetes after COVID. So there's something going on, but as Shivani is explaining, it's probably a mixed picture. There's probably multiple causes feeding into that, and it will take a while before we untangle it.
Lucy, anything to add there at all?
No, I think it's all been covered. As the others were saying, there's some observational data that shows an increased risk of people who've been hospitalized with COVID for later diagnosis of diabetes. And there's some mechanistic studies coming out with coronavirus infiltrating beta cells, etc. But as the others have said, there's many research gaps, But what's encouraging is there is a large, I think it's international registry being set up called the COVID registry, which is collecting data on new cases of diabetes that have occurred since the pandemic to try and understand this link better. But from a Diabetes UK point of view, that is a question we're asked a lot, and by the press as well, and it's a story that has run and run. So
absolutely, and I know that there's a paper just been accepted in its online publication by Kamlesh Kunti, who's the lead author, I think published last week, partly addressing some of the issues that we've just talked about, and the audience are directed to the Diabetes Care website, just looking up for that paper as well. So let me come back to some of the specifics, in particular some of the questions that have been coming through on. So there's a question here that's come through: is there any evidence that COVID vaccination reduces the incidence of diabetes? So Shivani, any thoughts on that?
Not that I'm aware of. Others can correct me, but I don't think. I think the big problem with questions of this nature are whether we're detecting the cases just because of better surveillance, that someone's come in, they've had their vaccination, they've had another health check, and they've been found to have diabetes a few weeks down the line. So I've not I'm fairly up to date with the literature. I've not come across any connection there, but I would be a bit skeptical if there was anything around that, because of this issue that we frequently see in medical practice, that is it cause and effect, or was it better detection?
Okay, Martin, anything to
add? I think it's a good hypothesis. So we have seen that vaccination will reduce the severity of illness, and that the people being admitted now are younger, perhaps less so more resistant to developing diabetes. So you might expect that vaccination would have an effect on the incidence of diabetes if there is this relationship. As I said, 5% of people who develop COVID appear to develop diabetes. So there isn't any data on it as far as I'm aware, but I think it's certainly a hypothesis that is worth testing.
Thank you both. I'm going to move to Lucy with a slightly different question now, a different emphasis, if I may. We know that there are data out there on the differential impacts in people from a health inequality point of view. So people who are potentially who are less well off, maybe people, or certainly people from ethnic origins, non-Caucasian origins, and the differential effect. And why do you think that those differences occur? What could be going on, do you think?
Oh, big question, Ketan. So yeah, I mean, from the population studies that we've seen people from certain ethnic groups, so people from South Asian backgrounds, Black, African and Black Caribbean backgrounds have higher risk of severe illness from COVID. We've seen people from lower socioeconomic groups having higher risk from COVID. And this feeds into the bigger question of health inequalities across the board. Why do we see them in these particular groups? We see them with diabetes risk as well with those same groups. So it's, yeah, I'll pass on to Martin to pick up the baton.
Back to you then, Martin.
Yeah, I think this is quite a difficult question, and I don't think there's a great deal known about it. There's certainly research going on in this area, but I think the underlying reasons for people in certain ethnic groups being adversely affected is unclear. Shivani may have more knowledge of this area. This is, I think, an area that she's particularly interested in.
Over to you, Shivani.
Yeah, I think we've got a lot of work to do here. I'm aware of a couple of studies that have adjusted, for example, for socioeconomic status differences, for diabetes and comorbidity differences, and they've still shown that there is higher risk of severe COVID. But I'm also aware of other studies that when you adjust for those confounding factors, then there doesn't appear to be any difference between ethnicities. So I think it's probably quite a challenging question to answer in a country like England, and we might have to look to abroad, where for example what's going on in India, etc., and looking to see whether that hypothesis is borne out. But again, one of the things I would say is that it's such a complex topic to disentangle in terms of, you know, when did lockdown occur in that place? What's the, you know, what are the comorbidities? Who's living, how many people are living in the house? There are so many factors that I wonder whether we'll be able to answer that question conclusively.
It's a difficult one, actually, because I think that in the UK, we have such fantastic reporting mechanisms and ways of capturing data. Whereas, you know, you're saying thing about India. I have a lot of family in India, I have a lot of relatives and friends in India, and I do suspect there's been significant underreporting of what's actually going on. So you're right, it may be extremely difficult to try and tease out all of the individual factors and the risks. And I just, staying with you, Shivani, there was the paper from John Valabji and colleagues from NHS England at the very beginning, really showing the differential effects of COVID in people with type 1 and type 2, particularly toward, as you know, the biggest differences were those who were above the age of 65 or 75, if I remember rightly, suggesting that actually it's much more of an age factor and possibly comorbidity factor than COVID per se. What do you think?
Yeah, I mean, this is a question I get asked a lot in my clinic. You know, people with diabetes worried about their overall. You're right. Age is by far the biggest modifier of, you know, risk of mortality from severe COVID, and it just, everything else pales into insignificance in relation to age. So I mean, of course, you know, there's the type 1 versus type 2 story there as well. There's obesity, there's the level of HbA1c you have, but yes, you know, if we think, going back to the previous question about ethnicity and you know, the Asian migrant population in this country or the first generation migrant population in this country is old, and that, as we know, they have a high risk of diabetes, and so these factors definitely have a very important part to play in the story.
Lucy, is that one of the fears that you get people asking you about?
Yeah, so people see the headlines, you know, 1 in 3 people who have died from coronavirus had diabetes, and that obviously rightly so worries them if they have diabetes. So we've done a lot of explaining around risk and what it means for you as an individual. We have parents of children with type 1 looking at these statistics, being really worried. But as Shivani was saying, we know that age is the dominant risk factor. The majority of people who've sadly died have been of older age. Diabetes is a contributing factor, but it's not the only risk factor, and it's a whole mix of risk factors that come into play. But what we're seeing with the data, I think, and probably explains some of the difference in risk between type 1 and type 2, is that diabetes complications, or the length of how long you've had diabetes for, plays into your risk of becoming seriously ill. So from our point of view, it's been really important to help people understand, yes, you are at risk, but that diabetes is just one part of the picture. And then this has also fed into our policy work around shielding. So as an organisation, we haven't called for a blanket shielding for people with diabetes. We didn't think that was appropriate because there's such differences in risk between different people with diabetes, although we have called for extra protections for those who are at high risk. So people with diabetes of older age and comorbidities, higher HbA1cs, etc.
Do you think it's the length of time that somebody's had diabetes, or do you think it's the comorbidities that they've had associated with diabetes that puts them at higher risk?
Well, I think those two are probably highly related. So it's put in simple terms, it's the damage diabetes has done on the body over time that probably puts people at high risk.
Martin, did you have anything to add to that one?
Yeah, no, nothing else. I mean, I agree that age is by far the biggest factor, and we know that the serious complications that occur in some people with diabetes, like renal failure, cardiovascular disease, they appear to be linked to an adverse outcome from COVID. So these are the key things, and how that's linked in with ethnicity is quite complex.
All right, I'm going to move on to a different subject, if I may, although of course related to COVID and diabetes. So Martin, I'm going to stay with you, if I may. Your recent data talking about access to healthcare, mortality, and so on. So we all understand that primary care has been under the cosh, and of course, just reported in the last few hours, I think, is going to be a huge amount of money spent on trying to help restore services in primary care, not just for diabetes. But how do you think that primary and secondary care and people with diabetes for themselves can help restore what we were like pre-pandemic, or even should we be like we were pre-pandemic, or should we do something different?
Yeah,
that's a lot of questions there. Sorry.
Yeah, well, it's a fabulous question, and there's certainly a huge amount to cover there. So we showed in our own work that access to primary care was limited, as we all know, but this has implications as far as the diagnosis of diabetes is concerned and the monitoring of diabetes is concerned. We showed that between March and December, the rate of diagnosis of type 2 diabetes was reduced by about 70%. And that's probably just access to healthcare. But and the rate of doing these care processes was also massively reduced. As I said before, 7.4 million health checks weren't performed last year that we would have expected to have been performed. But how do we tackle it? And I think it's unlikely that we're going to be able to get back to how we were before. And I don't think anybody really believes that that's the best way forward. One thing that has happened, I think, because of the COVID pandemic that's positive is that new ways of working have evolved, and probably evolved at a rate that we would never have imagined years ago. But certainly we do need more face-to-face contacts, and the funding that's been provided by the government announced today, that £250 million, will help to some extent. But I think lots of people who are critical of the government would say that's a drop in the ocean. I think making use of the technology that is available now, so we can remotely monitor some people with diabetes, perhaps more so in secondary care than primary care, but there's home blood pressure monitoring, home weight monitoring, home ACR monitoring, there's online there's support, there's educational resources.
So do you think those are going to work hand in hand with primary and secondary care? That's the way it should work?
Yeah, I think there's going to have to be, greater linking of primary and secondary care, sharing of expertise. There's greater use of digital technologies. I think people working in different ways in primary care. So peer support, group consultations, maybe pharmacists getting more involved, other staff being trained to do things like health checks that maybe weren't involved previously, and offloading the GPs so that some of the work that they were previously doing is done by others. So DVLA checks and fitness to work certificates, etc. So we need to free up the skilled workforce to do the things that they need to do. And clearly that's about prescribing. Health checks don't do anything on their own. It only really means something if we do bring in new diabetes medications, that we treat blood pressure, we treat lipids, and we do things that are going to actually have an impact on outcomes in people with diabetes. It's important to keep a focus on that. And I think greater use of newer agents as well. So we know that drugs like SGLT2 inhibitors and GLP-1 receptor agonists really do have major benefits to people in terms of prognosis, mortality, cardiovascular risk, renal risk. And greater use of those agents is likely to be beneficial, particularly in these times when people have been less monitored and risk factors have drifted. And maybe people are going to be compromised with higher cardiovascular risk and renal risk because of this lack of monitoring that's occurred over the past 18 months. So
that I was going to say that might put you in direct contradiction to NICE, the new updated NICE guidance, which is of course out for consultation, which doesn't quite go with what you said, but that's up for debate. I want to come to, sorry, thanks, Martin. I'm going to come to Shivani, because again, Shivani, I know you've done quite a lot of fantastic work on remote or postal HbA1cs and remote glycemic monitoring. Can you say how do you think that may work in the future?
Yeah,
help us catch up with what we've missed out on.
Yeah, I think that what Martin said, I agree with completely. And there are some fantastic opportunities where we've been, innovative over the last year to actually embed some of those activities in clinical practice. So yes, where I work, we very quickly actually put together a postal kit that will enable you to finger prick at home, collect some droplets of blood, and then we can process that in the laboratory for HbA1c. And there is, that is not a free thing, that costs. And I think local services, I mean, my thing, what I was going to add to what Martin said is that local geographies all need to get heads together to decide what is the priority in their area. We cannot get back to the way we were easily or quickly, and as Martin said, perhaps we don't even want to. So that, you know, every locality needs to come up, and there might be an area where postal HbA1c is useful. There might be other areas where, you know, the is to see the most vulnerable people face to face and bring them in and do a complete sort of MOT, so to speak. So yes, I mean, the pilot that we ran was really successful, and it definitely enabled us to continue monitoring some of our most vulnerable patients during the first and the second wave. And I think there are also, like, you know, Martin alluded to remote monitoring of people that have CGM, but which is a minority of individuals. So I think there are there's been lots of innovation. One thing that I'm very cognizant of, particularly where at the conference I'm at today, is that whatever innovation that we have, for example, digital innovation, doesn't disadvantage any sectors of society, because those people are the most vulnerable at the present time.
Thanks. I know you're at the South Asian Health Foundation meeting as well. So Lucy, can I come and bring you into this part of the conversation? So we talked about how people with diabetes have contacted Diabetes UK. Have healthcare professionals contacted you and said, what can we be doing differently?
Yes, I'm probably not the best person to answer that question, Ketan, because I don't work in the policy department. But of course, we've done a lot to support healthcare professionals throughout the pandemic. And as Shivani and Martin were talking about, at the moment, we're focusing quite a lot of work on remote consultations and how we can support both healthcare professionals and people with diabetes to make the most out of those sessions together. And we're also looking at the research gaps around remote consultation. So we have an initiative called our Diabetes Research Steering Groups, which are groups of people with diabetes, healthcare professionals and researchers that come together and talk around a problem and identify where the research gaps are. So we have a group working on remote consultations and making recommendations in those areas at the moment. And I'd have to work with I have to go to my policy colleagues to give you a full update on the
that's
huge
fine.
amount of work we've done with healthcare professionals. But
that's fine. Okay, let's move on a little bit. We've got a few more questions coming in. Let's just see. We've talked about technology. There's a couple of questions in the chat box, and actually been previously sent in. I think this is going to be a bit contentious. I'm not sure there's going to be an answer, but there are some people who have said that their diabetes was precipitated by the vaccination or came to light very quickly after they had their vaccination. So Shivani, can I come to you and say, do you know of any data that suggests that vaccination could have an adverse effect on in general health or precipitate diabetes?
No, I'm not good then. I'm not aware of that. And also, you know, there are lots of other vaccines that, you know, that we obviously have, and I'm not aware of any of those vaccinations being associated with the onset of diabetes. But as we said earlier, I mean, it is an interesting hypothesis. And anecdotally, when I talk to some of my people under my care with type 1, for example, they talk about an event that happened, you know, an infection or a stress event or something else, which then resulted in the symptoms. And I guess it's not outside of the realms of possibility, but I've not seen any robust data to confirm or refute that.
Martin, have you any data on that?
No, I mean, I think I've not seen anything that suggests that vaccination will increase the risk of developing diabetes. And as we've discussed before, it's more likely, I think, that the opposite is true, that being vaccinated will prevent it'll prevent severe COVID infection. We know that 5% of people who develop COVID do develop diabetes, but we'd expect that vaccination would limit the severity of that illness and would probably mean that there'd be less likelihood to go ahead and develop diabetes in the future. So that's obviously a hypothesis to be tested, but I would have thought that the opposite would be true.
Okay, thank you. Yeah, it's just a matter of waiting and watching, I suppose, looking for the data as it comes out. I'm going to stay with you, Martin, again, if I may. I'm going to pick you up on something that you said right close to the beginning of the conversation. And one of the things that we know about in terms of treating moderate to severe COVID was the use of dexamethasone, as the recovery trial showed. And I'm sure the audience will all be aware, as we are, that the use of steroids worsens glycemic control. And yet I don't recall seeing any data yet on what happens to the diabetes in those people who have got COVID, which is treated with dexamethasone, and whether there's a difference in the recovery, or no pun intended, or in the outcomes of those people who develop hyperglycemia on steroids and those who don't. Do you know of any data that's out there yet? We're waiting for the recovery trial data, of course.
Yeah, no, I'm not aware of anything at the moment, but you'd expect that, steroids, they clearly cause diabetes, but if they reduce inflammation at the time of the illness, and maybe they limit the amount of pancreatic damage, we were talking about the potential for the virus to cause inflammatory damage within the pancreas, you might expect that it will be a short-term problem, and then when the steroids are reduced and stopped, that apart from perhaps residual obesity, but once that is resolved, that the likelihood of diabetes would be less as a consequence of having the steroids in the first place. But again, that's it's hypothesis, but that would be the way I would look at it potentially.
Okay. And Lucy, do you get people calling you about dexamethasone and alternative treatments and what they should be doing to look after themselves, or how they can minimize the risks as well?
So we tend not to get too many calls about actual treatment for people who have been hospitalized with COVID, but we've had a lot of calls about vaccines, many calls about vaccines, calls about the effectiveness of vaccines in people with diabetes. And we've looked at that evidence, and there's no evidence at the moment that we can see to show that the vaccines might be less effective in people with diabetes, which is reassuring. We get calls about people concerned about going back to work and protecting themselves there, and our recommendations obviously always to the best form of protection is to get vaccination and the booster when you're offered it. And then we get questions around what can people actually do to reduce their risk, other than the standard, social distancing, vaccine, those sorts of things. And we know that HbA1c and high body weights have come out as risk factors for getting seriously ill from COVID. So we encourage people to work with their healthcare teams to focus on those factors if they can, to reduce their risk over the longer term.
Okay, Shivani, anything you'd like to add?
No, I think the stress hyperglycemia story is a really interesting one. And I just wonder also whether there's an element of, this unprecedented situation where we're giving steroids, high doses of steroids at a population level, and people that have used those kinds of doses of steroids, for example, oncologists will frequently see diabetes tail off insulin doses, and the patient manages to come off insulin. And I think part of this is we've got our sort of magnifying glass on this situation, looking for something new. But I just wonder, and this is not proven, but I wonder whether there won't turn out to be anything particularly new here, other than the fact people have been desperately unwell, catabolic, had steroids, got very sugary, and then a few weeks or months later it's resolved.
You see, I come from I come from it from a different hat, you see, because for those of you who don't know, I'm interested in inpatient diabetes, and I'm aware that just as with gestational diabetes, a woman whose diabetes may go away the moment that placenta is delivered, they are always at risk of developing type 2 diabetes in the future, and they always need to be screened annually to check where they got it. And I know that there's a lot of data from the inpatient world to say that if you've developed stress hyperglycemia, even though it may resolve when you recover, you are still at much greater risk at some stage in the future, so that people ideally should be screened, although that's not as commonly known, which is why I always wonder, particularly in this situation where there's dexamethasone use and people do become hyperglycemic for whatever reason, whether we ought to be following them up and saying, well, are you at increased risk of developing diabetes in the long run?
I think that's a really important point, Ketan. I think that it's a challenge. The body is being challenged by being sick, having an inflammatory response and having steroids, in the same way that a pregnant woman is, challenged by pregnancy. So yes, what it tells us is that the person that gets hyperglycemic versus the person that doesn't, under the same circumstances, their beta cell function or their ability to compensate for that is at a different level. And yes, I think what you've just said is amazing. I think I don't know how we follow all of them up, but we need to make sure that they're getting an HbA1c check, even if they come off their medications later.
Yeah, that's just burdening the primary care even further. I'm sure I'm going to get a lot of brickbats thrown at me, I'm sure. Okay, right. Yeah. Sorry, Martin, you were going to say?
Yeah, well, I think, people have developed COVID often, on a background of being in lockdown. They've gained weight, they've become deconditioned, they've had less physical activity, they might be stressed. Then they get COVID and then they develop diabetes, perhaps as a consequence of steroids precipitating things. And I just think there is an opportunity potentially for some of the newer agents that we talked about before, SGLT2 inhibitors and GLP-1 receptor agonists, that could potentially change the natural history of the diabetes in these people who develop it after COVID. And
so expand on that, Martin. Expand on that. Just keep talking. What do you mean by that?
Well, these agents they encourage weight loss, and we know that they have other potentially beneficial effects that could, I think, be particularly useful in these groups. I think we need clinical trials, obviously, to prove the benefits of these drugs. And I know that some trials are ongoing in this area, but I just think we've got drugs that are particularly beneficial in our patient population, and perhaps these individuals who develop diabetes in the setting of COVID could benefit particularly from them.
So you think they should be used earlier in the pathway rather than just wait, delayed a few years down the line?
Well, it certainly should be tested, I think. I don't think we have any evidence to sort of support, the routine use of them, and I wouldn't want people to take that away from the presentation today. But I certainly think that it would be good to do studies to see the value of these agents in this setting.
Okay, thank you. Now I'm going to shift again, because there's a beautiful question which I think is probably best aimed at Lucy, actually. We've talked a lot about diabetes and COVID and so on, but it's actually a question which is, how can educators such as teachers get involved in raising awareness for spotting the signs of early diabetes, or even diabetes in general? What are the things that people ought to be looking out for to think, could this be diabetes?
Are we talking general population? General
population, yes, please. General population.
So we have, we say look out for the 40s. So
which are
toilets, going to the toilet more, being thirsty, i.e. having gone to the toilet a lot more, being tired, and thinner as you lose weight. So those, obviously with type 1, those symptoms will come on quickly. Usually in type 2, they can come on a lot slower, but they're the 4 symptoms of both types of all types of diabetes that people can look out for. And obviously with type 1, you need to act very quickly.
And I know there's evidence, in particular from Italy, showing that in schools where there is a child with diabetes, they tend to pick up other children who may develop diabetes much more quickly. So a general education of everybody around, particularly staff in schools, is really, really relevant in this circumstance. And there's another question that's come through. Again, this is not necessarily related to COVID particularly, but it's just, I think, general education for the wider public about, in people with diabetes, should people be doing an annual sugar test, a urine sugar test, to screen for diabetes? What do you think to that, Lucy?
Well, it depends how they've been identified as being at higher risk. We know that I think it's 13.9 million people in the UK are at higher risk of developing type 2. So that's a huge chunk of the adults.
And what puts people at higher risk, just for those who don't know in the audience?
We know it's a complex mix of genetic and environmental factors. We know obviously body weight plays a large role. So it's obviously carrying excess weight, but it could be a weight around the internal organs, the pancreas and the liver. We know that age is a risk factor. We know that ethnicity is a risk factor, but we know genetics play a huge role as well.
Okay, and as we mentioned about gestational diabetes, being on steroids, being on all the other things as well.
Yeah, and we know that people who've had gestational diabetes are more predisposed to developing type 2 in the future as well.
All right, listen, I'm really very wary of the time, and I know we're coming up towards the end, and I just want to ask for any final comments. So Lucy, you're still on my screen. So do you have any final comments for the audience about how we can be doing things differently and how we can be helping those people with diabetes or at risk of diabetes?
As we emerge from I think we need to get care back on track. We know from the data coming out that many people still haven't had all their critical checks. And we need to continue to provide people with diabetes with accessible information about COVID. What we don't know, we know a lot about how diabetes plays into risk of becoming seriously ill. What we don't know much about at the moment is long COVID. We get lots of questions about that. Are people with diabetes more predisposed to long COVID? How does it affect their control if they do get it? So that's a whole area where we just need time and data to be able to answer those questions. But I think keeping people updated on the science, and that's obviously my job.
Thank you. Thank you so much. Shivani, any final comments from you about what we've said today?
I think, covered such a breadth of topics. I think that to get back on, to get back on track, or however you want to describe it, my focus will be on the vulnerable people under my care who I think have suffered disproportionately. And I think we need to address the missing cases that Martin alluded to earlier, that, the people that we've missed diagnosing because they haven't had their checks. And I guess that what I'm saying there is we need multi-pronged approaches. We need to, for me, I'm the individual in my clinic, but at a more higher level, we need to think about the population, find those missing cases, get the health checks done, etc. I would just also say the biochemist in me is rattling, because I just have to say we don't screen for diabetes with urine dips for glucose, and I wouldn't want anyone to go away thinking we should do that. So if you're worried about whether you have your diabetes or not, there is a blood test that we can do, and you should encourage you to reach out to your GP if that were the case. Biochemist
first and foremost. That's very important. Yeah, very important. Thank you for that. And Martin, coming to you.
Yeah, Ketan, it's been a great discussion. Very wide ranging. I think probably the main messages that I'd like to get across are that I think the COVID pandemic has given us an opportunity to change the way that we deliver diabetes care, and innovative pathways have already started to evolve, and I'd hope that that would continue and, if possible, accelerate. I think greater use of digital technologies is going to help us, and it may be eventually at some point in the future that we'll be able to monitor diabetes remotely in people's homes, and provide a very good service that way, that education and training that sort of intervention can be delivered at home, and that we should embrace these changes. It's difficult to change systems and to change the way that people practice, but I just encourage people to embrace those changes. I think primary care needs a lot of support. I think it does need more funding. It needs more, probably, practitioners, practice nurses and GPs to deliver the sort of quality of the care that our patients deserve. So that's just a plea to the government to put more resources in.
And just to jump in there, Ketan, we are running a campaign at the moment called Diabetes Series, and we're pressing the government to make diabetes care central to its recovery plan from the pandemic. So people can go on our website and find out about what we're doing.
Yeah, that's fine. Thank you, Sam. I know, well, for those of us who look after people with diabetes, of course, it's an absolute priority to get them, ensure they have the best care that they can. Now, and that just leaves me to say thank you very much to Lucy Chambers and Shivani Misra and Martin Rutter for their fantastic contributions. Now, before we go, I have got a few plugs. Now, we've just talked about the government response to the COVID pandemic, and for the audience listening, we have an absolute coup. In 2 weeks from today, We have Jeremy Hunt, the former Health Secretary for the United Kingdom, talking on the COVID-19 series, exactly about the report that has just been published, which he has led the authorship on the government's response to the pandemic. So please do tune in for that in 2 weeks from today. On the 25th of October, we have the Dan Guer lecture, which is going to be delivered by David Spiegelhalter. And for those of you who don't know, he's the professor of science communication from Cambridge University, and he's a very good communicator about science. So I would encourage you to join that lecture as well, which is free to everybody. And then on the 23rd of November, we have Dame Sally Davis, who is the former Chief Medical Officer for England, talking about antimicrobial resistance in the COVID pandemic. And finally, we have the Chief Political Editor for Talk Radio, Pete Cardwell, talking as well. So please do join us for all of those fantastic talks. And once again, I thank my fantastic panel for a wonderful conversation. And I hope all of you around the world who are watching have a fantastic rest of your day.